everyone. Thank you so much for joining us tonight for the webinar From Surgery to Recovery, Advocating for Yourself Through Bladder Cancer. I'm Teresa Blondin, the Director of Volunteers and Programs at Bladder Cancer Canada, and I'm so honored to be facilitating this session tonight. At Bladder Cancer Canada, we aim to be reactive to patient needs and concerns. And this session was actually created in response to an issue that came up during one of our support group meetings, a patient who experienced a serious side effect after surgery and felt she did not receive the urgent care she needed. In this session, we hope to give you the knowledge and language to feel empowered to advocate for yourself and communicate with confidence to medical professionals. So now I'm honored to introduce our presenters for today. First, we have Dr. Justin Lee. Dr. Lee is a urologist at Lionsgate Hospital, Vancouver Coastal Health, with a focus on diagnosing and treating genitourinary cancers. He has advanced training in minimally invasive, laparoscopic, and open surgical treatment of urologic cancers. Dr. Lee is also active in teaching and research as a clinical assistant professor at UBC, with interests in patient-reported outcomes and quality improvement. And I'm also so pleased to welcome back Rosemary Hill. Rosemary is a wound, ostomy, and continence nurse from Lionsgate Hospital. With over 35 years' experience, Rosemary has been recognized with the Award of Excellence in Practice from the Association of Registered Nurses of British Columbia. She previously served as the president for Nurses Specialized in Wound, Ostomy, Continence Canada, and she's an active member of the BC Provincial Skin and Wound Ostomy Committee and chairs the Provincial Ostomy Committee. And she's an expert speaker at national and international events. So thank you both for being here, and I will pass the floor to you.
Thank you, Teresa.
Thank you, Teresa. I'm so excited to be here today. Thank you for the invitation, and I hope tonight will be fruitful, enjoyable, knowledgeable, and feel free to post any questions on the chat group, and looking forward to answering anything you propose there. I am going to start the slideshow. Hopefully you can all hear me from all the way out here in the West Coast. I see from the chat group there are a couple of us British Columbians here, so happy to see you guys here too. So from coast to coast, happy to have you here. And so, as mentioned, the objectives today are as follows: is to review some of the postoperative recommendations to assist with a smooth recovery, kind of highlight some red flags to watch out for postoperatively, some practical travel tips after a cystectomy, and ways to optimize communicating with your healthcare team and being an advocate. And so being an advocate is going to be sprinkled all throughout this presentation tonight. And so as a disclaimer, kind of like what Teresa just mentioned, I don't have any conflicts of interest. I'm not sponsored by any organization for this. And this is just a general bladder cancer talk. And as many of you know, bladder cancer comes in many shapes and sizes, and one size does not fit all. So it varies from patient to patient, tumor to tumor, biology to biology. Is very variable. And so just consider this a general talk, and obviously talk to your specialists for anything detailed about your own personal health and questions pertaining to your cancer there. So I'll start by saying, addressing what was in our title, which is kind of advocating for yourself through the journey of your bladder cancer. And so what is an advocate? I kind of looked this up so that I can make sure I touch on some important points throughout this evening. And so in general, an advocate is someone who supports, of course, or acts on behalf of another person, group, or cause. And that person represents someone's needs, rights, or interests, provides support, whether it's emotional or informational, and helps to take action to either solve problems, remove barriers, promote change, or quality improvement. And so that's in general what an advocate does. And in particular, patient advocates may help with medical information and understanding. They can ask questions, help coordinate care, and assist with practical issues. And so a patient advocate can be really anyone. It could be the patient, him or herself. That's self-advocacy. And all of us are here tonight, whether you're a patient or a family member. So that's a good start. And a family member or friend can be an advocate. It could be a healthcare professional, like a nurse, navigator, or a social worker. It could be a trained advocate from a hospital, community group, or a patient organization, such as Bladder Cancer Canada. So over the years, I've through clinic and through learning from my patients, I've seen the whole gamut of who are good and effective advocates and those who may not be as strong. And so some of the qualities or important trademarks or characteristics of a good patient advocate I find are as follows. First, it's important to learn the basics of the diagnosis and treatment. And so that's what a lot of tonight's going to be about, is learning some of the basics about the diagnosis and treatment and also some of the complications, side effects. It's important to listen to the patient's goals and what matters to them in an empathic, compassionate way. Ask clear questions and request explanations when needed. Fourth, to keep organized notes. I think that's important. Feel free to take notes tonight or come back to the webinar. And I know Bladder Cancer Canada has a lot of available resources. And so that draws to point number five, which is to use available resources, whether it's nurse navigators, social workers, and support groups. A good advocate is particularly effective at supporting emotionally their well-being and to help reduce anxiety and stress. And also, lastly, to encourage independence and autonomy whenever possible. So we'll, over the next couple of slides, kind of learn about the basics of diagnosis and treatment, and that's the very first step to being a good and effective patient advocate. So when you're going to the clinic, you're going to be hearing a lot of different parts of the body and anatomy, and you may be reviewing CT scans with your physician, and so it's important to know a bit of basic anatomy. And so the urinary system, genital urinary system, consists of the kidneys. And then on the left-hand side is a male patient and then a female patient on the right. And so we generally have two kidneys, a ureter, which is a tube that drains urine down from the kidney down into the bladder. And the bladder stores the urine until when it's appropriate to empty the bladder. And in the males, it travels through the prostate, out the penile urethra, and out the penis. And then in ladies, they don't have prostates, and so it would just come from bladder through the urethra. And so that's generally the main parts of the genital urinary system. And so the genital urinary system spans from the abdomen and into the pelvis. So it spans two parts of the body. Bladder cancer is a fifth leading cause of cancer in Canada. There's going to be over 10,000 diagnoses per year in Canada. It starts when cells in the lining of the bladder grow abnormally. And most bladder cancers begin in the inner layer of the bladder wall called the urothelial layer. That's kind of like the lining of within the bladder, and the bladder has several layers. It has the urothelium, as I just mentioned, and then it has a detrusor muscle, and then it has an outer layer as well. So bladder cancer starts in the urothelial layer, but can invade or progress through the layers of the bladder. And this portends a more aggressive type of bladder cancer. It usually presents with blood in the urine, though other symptoms and signs can happen, like changes in urinary symptoms, going more frequency urgently, or pain symptoms, pelvic pain. Sometimes it could be presenting with flank pain or pain in the loin area, or sometimes it could present with fatigue or weight loss. And so there's many different ways that bladder cancer can present, but the most common way is through blood in the urine. It is one of the most common cancers of the urinary tract, and smoking is the biggest known risk factor for bladder cancer. And there are several other risk factors. Bladder cancer tends to be more common in men. 75% of them happen in men, but it does happen in females as well. Chronic irritation of the bladder, chronic inflammation, and infections can lead to bladder cancer as well, among other risk factors. So I believe tonight, based on some of the questions that have already been received, that gather that there are patients and also family members or advocates or friends who are dealing with bladder cancer along a spectrum. And so I'll start from some of the beginning basics of the early phases of bladder cancer diagnosis, out to cystectomy and surgeries for aggressive bladder cancer. So once a patient is presenting with blood to the urine to their family doctor, that patient is normally referred to a urologist who would see you and assess you and perform some tests. And some of those tests include a physical examination, a history of getting an idea of your risk factors and history of presenting illness, as well as what medications you're taking. And a urine test is commonly performed called a urine cytology, which checks for cancer cells in the urine. Once those are all performed, a cystoscopy is the next standard test for anyone presenting with visible blood in the urine. A cystoscopy is a simple procedure that lets the urologist look inside your bladder and urethra, and is performed usually in the urologist's office or in the hospital. At Lionsgate Hospital in North Vancouver, I perform it at the hospital. We don't do any in office, but other centers like at Vancouver General Hospital, they tend to do it in their office setting. Um, it doesn't matter where. And it's often performed with a local anesthetic. It's usually a local anesthetic that is within a syringe-like tube, and it acts as lubrication as well, and has about 2% xylocaine jelly to help with making it more comfortable to perform this cystoscopy. Sometimes a bladder biopsy may be performed during the same procedure. We can use instruments, little graspers that can go through the cystoscope in order to perform a biopsy, and also we can put a cautery through it to cauterize any lesions that we might see. Again, that's very patient specific. We don't always do it, and it just is possible if needed. And usually the procedure takes less than 5 minutes, often faster than that. And so you should be able to go home right after the cystoscopy. Um, After the test, yeah, you might feel a burning sensation when urinating. This usually resolves by the end of the day, or it might take a day or two to resolve. You might see a little bit of blood in the urine. Sometimes just placing the xylocaine jelly into the urethra can induce a little bit of bleeding. And also passing the scope through the urethra and then past the prostate and into the bladder can induce some bleeding. And then also, if a biopsy is performed at the cystoscopy, it can also induce a little bit of bleeding. But generally, it's a very small amount of bleeding, which clears up again, by the end of the day, or might take a 1 or 2 days to resolve. Um, we often recommend to drink plenty of water to help flush the bladder, and it's good to go to the washroom um, fairly frequently, even if you don't feel like you have to after a cystoscopy. So kind of set your timer to go every 2 to 4 hours, even if you don't feel like going, just to clear out the bladder. And you can generally resume a regular activity right after the procedure. Uh, Now, in terms of some red flags or things to call the urologist's office immediately, is if you develop any fevers or chills, this could indicate a possible infection. If there's any persistent or heavy bleeding, so if the bleeding is happening for beyond the expected 48 to 72 hours, or if you're seeing large clots and you're not able to urinate, that suggests that you're not fully emptying your bladder, and then it might necessitate you calling your urologist. If you have severe pain, that's just not improving. It is safe to take Tylenol after the procedure, but if you're having really severe pain that's not resolving with just simple over-the-counter pain medications, then it's something to call your urologist about. And of course, if you're having a lot of trouble urine, you can't pass urine at all, you're only dribbling out small amounts, it could mean that you're in urinary retention and you would need to go back to the emergency to be checked out. This happens very rarely, but it can happen because when we're placing the flexible cystoscope, it can cause a bit of inflammation, sometimes some edema around the prostate, and make it more difficult for men to urinate and develop urinary retention. So that's a cystoscopy. It's generally very, very safe, very quick, and you're home the same day. Now, once a bladder lesion is found, say the blood in the urine is investigated, a tumor is seen, then the next procedure that is recommended by urologists is a transurethral resection of bladder tumor. Short, we call it a TURBT. Other, you might hear in other places a turbot. It's for short. And so this is a surgical procedure which is more involved than a cystoscopy. It's done through the urethra like a cystoscopy, but it's done in a hospital setting and is done under a general anesthetic or a regional anesthetic, such as a spinal anesthetic. Um, the purpose of a TURBT is to biopsy and remove any abnormal tissue that is found during the cystoscopy. The material or tissue, the abnormal looking lesion, is removed and is sent to the pathology lab for analysis under a microscope to determine A, whether it's cancer or not, B, what grade of it is it high grade or low grade? Or number three, the depth of invasion, whether it's invading into the connective tissue of the bladder wall, what we call lamina propria, or is it going deeper into the muscle, or and so that can determine and dictate what the treatments are following that. Generally, the TURBT takes less than an hour to an hour and a half. In general, usually it's even shorter in general, less than an hour. And a catheter is sometimes placed into the bladder at the end of the operation. That catheter may stay inside the bladder for just around the time of the operation and the day. Sometimes it's done as a day procedure, and the catheter can be removed before discharge. Sometimes there may be some irrigation placed where it flushes out the bladder, and you might be kept overnight, whereby the catheter can be removed the next day. Or sometimes you might be discharged home with the catheter and be instructed or have follow-up to remove that catheter several days later, whether it's 5 days or 7 days, depending on how your urologist feels and how long the urologist feels it should be in place for. And also, during a turbot or TURBT, the urologist may prescribe a chemotherapy drug that stays in the bladder to dwell in there for about an hour. And this chemotherapy is called gemcitabine. Other places can use mitomycin, but the most common one that we use here in British Columbia is gemcitabine. And it's been a chemotherapy drug, same type of chemotherapy you may have heard through for other cancers, but this one is not put through the vein. It's placed through a catheter, a Foley catheter into the bladder and is clamped so that the bladder, so that the chemotherapy can stay in the bladder for about an hour to dwell. And you may be asked to position yourself or roll just to so that the medication can swirl around the bladder. And this is used to prevent the recurrences of bladder cancer. So after the surgery, you may see some pink urine. You may see some small blood clots for a few days. And often I hear from patients, and it's very common, that you would recover from the um, uh, turbot procedure and you'd be urinating clear for 2 to 3 weeks. And then all of a sudden, one day, you may be out walking and you see some blood in urine. This is very common, and how I kind of reassure patients is kind of like a scab that's on your skin, a scar that falls off after a few weeks, and then there's a little bit of raw area that can be a bit can bleed a little bit, but in general, it stops bleeding within a day or two. And so there's nothing, so it's very common to expect clear urine and then a bit of blood 2 to 4 weeks after the operation. It does not mean that your cancer has necessarily recurred or anything like that. And so that's just more reassurance for the patient, for any of you that might see that. It's good to drink plenty of water to flush the bladder out. And again, as I mentioned, you may be discharged home with a Foley catheter. And certainly at our hospital, there's a nursing team that will teach you how to manage the catheter, how to empty the catheter, and we may even teach you how to remove the catheter on your own prior to discharge. It's common to find some burning with urination, frequency of urination urgency to urinate, meaning it's difficult to postpone urination and might be common to see some small blood clots in the urine. So some of the problems or complications that can happen after a transurethral resection of bladder tumor include bleeding that requires a catheter to irrigate the bladder. Well, that's called continuous bladder irrigation. A small hole or perforation in the bladder can happen. We're using a resectoscope, which is a little wire loop to scrape and open up to remove the tissue, but it can go deep and cause a hole in the bladder called a perforation. Uh, in fact, when that occurs, when a perforation occurs, in most cases, it can just be managed conservatively without need for a reoperation or anything. It can be just managed commonly with just a Foley catheter and it allows that to heal. It would just mean that you would have to go home with a catheter. Infections or fevers can occur after a transurethral resection of bladder tumor. In general, um, as part of your workup with the urine tests, a urine culture is often performed for a general workup for blood in the urine. So we would know whether or not you had some risk for infection before the operation. Just prior to doing the procedure, after you're under a general anesthetic, it's common practice to give a dose of antibiotics, usually intravenously, but it can be given orally in the waiting preoperative area, and that's to prevent infection. Very rarely do we send patients home with an antibiotic unless there was a reason that we were suspicious of an infection or urine culture results prior to the operation suggest an infection. We may suggest having some antibiotics post-operatively to go home with. Um, Tumor can come back. Bladder cancer, part of the nature of it is a recurrence, and so that we will talk and touch on that. Urine retention is another problem, kind of like what I mentioned with the cystoscopy. We're manipulating the urinary tract, and when we manipulate through the urinary tract, especially in men with prostates, it can induce a urinary retention. Not only that, patients are undergoing a general anesthetic routinely, and the general anesthetic itself can induce urinary retention. Stress of the operation can cause urinary retention as well. Kidney obstruction can occur after a transurethral resection of bladder tumor. Usually, it's due to the fact that the tumor is overlying the where the ureters, the tubes that drain urine from the kidney, into the bladder. And sometimes when we resect, it can rarely, but occasionally, cause scar tissue or an obstruction at the ureter orifice, we call. So, in terms of red flags, very similar to a cystoscopy. If you can't urinate, you're in your complete urine retention, then it's important to call your doctor or go to the emergency. If you have any fever or chills, if you have any very heavy bleeding with big clots where you can't urinate, that's important. And severe pain, abdominal pain or bladder pain that's not resolving with medications, it's important to call your doctor about that. So once we've done the transurethral resection of bladder tumor, your family doctor or your urologist rather will follow up with you in 2 to 3 weeks after the operation in general, and that's by the time the pathology results will have returned. And depending on the pathology results, it could mean not needing any more treatments, but just looking inside the bladder under surveillance. So with repeated cystoscopies, it could mean going through some further treatments inside the bladder for non-muscle invasive bladder cancer that involves putting some medications, what we call BCG, into the bladder to help prevent recurrences. Or if it's a aggressive type of cancer invading into the bladder wall, what we call detrusor muscle, or if there were features of the non-muscle invasive bladder cancer which were very aggressive, then uh, a more uh, a surgery in the form of radical cystectomy may be recommended. Now, I'm not, for the purpose of today's talk, I didn't go into all the details of BCG. That's a whole another discussion and evening. But I do note that, again, through the bladder cancer, there's lots of material related to that. So, Radical cystectomy is what a urologist would perform, and it is the removal of the bladder and new nearby organs. So, what it involves is removing the bladder entirely, and for men, it involves removing the prostate along with the bladder. And so some of urologists would call that cystoprostatectomy. In females, commonly the uterus is removed as well as part of the vaginal wall, and the urethra is removed along with the bladder. In the operation and during the operation, lymph nodes are also removed, and so that's part of the operation. The pelvic lymph nodes, we call it. Um, and so that's part one of the cystectomy. The next part of the operation is to create a diversion or a new way for urine to leave the body. The ureters are now unattached from the bladder and it needs a new place to drain urine into. And there are different ways of draining urine into a new system, one of which is called the conduit or ileal conduit. This is what you see in the top diagram, where the ureters are connected to a segment of the small intestine, and that is connected to the abdominal wall, usually on the right side of the abdomen, whereby it would drain into inostomy, which we will have a more a thorough discussion later with Rosemary. And the other way is to create a neobladder. It's a way of forming a new bladder using the intestine. We use a longer segment of intestine and we form a bladder and then we reattach it to the urethra. And so you would be able to urinate through the normal urethra, which you're normally accustomed to. Or there's a pouch, something called the Indiana pouch, where you can use the small bowel and a little bit of the colon to formulate a pouch, which you can use a catheter to catheterize to drain periodically, but you do require a catheterization or catheterizable channel. Okay. And so for radical cystectomy, it's often preceded, the surgery itself is preceded by chemotherapy, what we call neoadjuvant chemotherapy. And so, depending on what your urologist thinks, may refer you to a medical oncologist before your actual radical cystectomy to determine if you're a candidate for neoadjuvant chemotherapy to prevent recurrences and improve survival following bladder cancer surgery. I tell my patients it is considered a major operation and can be a lengthy recovery. What to expect? The hospital stay is about 5 to 10 days. You'd be once you awake from the operation, you'll have several intravenous lines. You'd often have an epidural for pain control or a PCA pump to help with pain control. You'll have a stoma, and if you have an ileal conduit, or a catheter if you've had a neobladder. You'll have some drains to help monitor what's going on for any complications, bleeding, or urine leaks. One of what generally keeps patients in hospital is really the return of bowel function. That usually does take some time, generally 48 to 72 hours after the operation before the bowel function completely returns, and it can often lengthen a person's stay in hospital. That usually is what keeps patients in hospital is their bowel function awaiting to return. And it's normal to feel tired and weak for several weeks following the surgery. Some general tips for helping recovery. Walking is important. I think walking is the best medication. I kind of make a goal for my patients to walk 10 laps around the hallways every day. It doesn't have to be right away, but it gives my patients something to aim towards. But walking is the best medication. Drink fluids, eat protein and fiber, keep up with checkups with your urologist, and always feel free to ask your team for help or support. So, some of the common complications that we encounter with following a radical cystectomy are infections, bleeding, bowel issues, blood clots, wound problems, and other complications such as hernia, strictures, and urine leaks. When it comes to infections, infections can come from either the wound incision, um, it can come from the urinary tract, and so that can cause what's called a kidney infection or pyelonephritis. And sometimes just being in hospital, you can develop hospital-acquired infections and pneumonias, and so that can happen. And so that's something we, as urologists and the team taking care of you, will monitor for regularly throughout your hospital stay. Bleeding might require a blood transfusion. And so we monitor that through blood work, including blood tests daily or every other day. We have a drain inside your abdomen called a Jackson-Pratt drain commonly, and that's to monitor for any significant bleeding. And then your physician will be performing a physical examination to assess for bleeding as well. Bowel issues, as I just mentioned, that's one of the more common complications we see following a radical cystectomy, and that's called an ileus, and that's where the bowel is temporarily paralyzed because of the anesthetic, because of bowel manipulation, because of the surgery on the bowel itself. It can slow down the bowel function. Another uh, complication related to the bowel is a leak. A leak can occur from where we connect the bowels after we've harvested a segment for the conduit or for the neobladder. And so a bowel leak would then lead to fever and infection inside the abdomen. Blood clots. Uh, these are so blood clots can commonly occur after a radical cystectomy for many reasons. One is the surgery itself causes an increased risk of clots. Malignancy is a risk factor for causing clots formation. And then thirdly, just being immobile after the operation, laying up in bed can preclude or predispose you to clots. And clots can occur in the extremities and the legs, or it can and then that can travel into the lung, and that causes what's a clot in the lung called a pulmonary embolism. There you see a PE. And so we do many things to prevent this. We give a blood thinner before the operation, just around the beginning of just before we start the operation, what we call heparin, to prevent that. And then during your hospital stay, you'll be given either heparin or enoxaparin. And then going home we often teach you how to self-administer enoxaparin for a month following the operation to prevent clots. Wound problems are another complication. There could be what we call dehiscence or separation and or delayed healing, whether it's from infection. And so that can be a problem. And then other complications can occur down the road. These are more things that don't happen immediately, but in months down the road, you can develop hernia through the main incision of the operation or around the stoma called a peristoma hernia. Strictures can occur where the ureter is attached to the um, uh, a conduit or to the neobladder, and urine leaks can occur as well. And that's more in the acute or short-term operative setting. So when to call for help? The theme is generally the same: fever, chills. If you're having excruciating pain that's not resolved with pain medications, if you're not eating or you're having vomiting, redness or discharge from the wound, all of those reasons are why you should call your doctor for help. Now, I understand that. I believe a pulmonary embolism was one of the impetus for this evening's talk, and so I mean, for clots in the leg, it's important, particularly to look out for any swelling or pain in the lower extremity, such as the calf, and if it's happening only in one leg, for instance. And so, like if you try to flex your heel or your ankle and you have pain in the back of the calf, or if you have swelling in one of the legs compared to the other, it could mean that there's a clot in the leg, and that needs to be checked out urgently. So you should call your doctor immediately. If a clot has traveled to the lung, It's called a pulmonary embolism. And one of the common symptoms you might feel for that is shortness of breath. Chest pain can occur and difficulty breathing. And in particular, there's something called pleuritic chest pain. So when you breathe in deep, there's pain. It's certainly something to warrant going to a hospital to be checked out. And so those are just some important points to highlight when it comes to clots and what we call deep vein thrombosis in the leg. So going back to being a good patient advocate, I've talked about some of the basics about diagnosis and treatment and what to expect. Another important aspect is really to listen to the patient's goals and what matters most to them. And so if you're a self-advocate or if you're a family member or friend, it's important all throughout your journey with a cancer diagnosis is to review your patient's goals. And goals can change as your journey progresses. When you first meet someone for the first time with a urologist, your goals might be different from after you've been through several treatments and things like that. And so, and after you've had a diagnosis, and what treatment options are available to you. So it's important to have this discussion of goals of care. And it's important to explore values and fears and preferences of your friend or family member. Um, these are values like, how aggressive do you want treatment? This can be what fears you have. Is it pain? Is it of cancer coming back? Is it fear of even going to the hospital? I had a patient who had a post-traumatic stress disorder from an early experience from a knee operation going into hospital, and that required a lot of counseling beforehand and preparation, but that's important to address these fears and preferences. Some prefer surgery, some prefer radiation, some are colored by their past experiences with other cancers that they've had. And so all of these are very important things to explore and have a discussion before and after visiting your urologist. And then advanced directives. I always bring it up, and your anesthetist will often talk about your advanced directives before the operation when you see them for a pre-anesthetic consultant. And this is important to let your physician, your family doctor, and your urologist know about any advanced directives or a living will that you might have. Keep organized notes. So patients that I find are effective advocates are ones that come prepared. And so, for instance, for your initial consultation with the urologist or with your anesthetist or your medical oncologist down the road, bring your medication list all the time. Even if I met you 10 times, it's still good to bring your medication list or your medications in a bag. It's so important to just have these medications available. Bring a summary of your list of health problems, such as your past medical history, and even the things that you have undergone. And then come with your questions written down. That's really helpful. I always welcome my patients to bring, or even so if you have an upcoming appointment, feel free to submit your questions beforehand, before your visit. And, I know urologists are often busy, but sometimes we can get to those questions so we know what to address when you come to the appointment beforehand. So feel free to drop off those questions at the office if you need. And so that's some ways to be an effective advocate that way. There's a wealth of resources out there. Bladder Cancer Canada, again, huge repertoire of resources. The Canadian Urology Association has online patient information and material. And so that's important, a way of getting available resources. And so, yeah, I just wanted to end there and hand it over to Rosemary.
Sure. I know there's a couple of questions, but Teresa, should we take those at the end or is now a good time? What do you think would
Yeah,
work best?
I think we could take them at the end and see if there's any more
Okay,
or you cover any of them as we go.
sure. Sure. Um, I'm just going to lightly touch on things around travel. And in some ways, I so appreciated Dr. Lee's covering all the different types of bladder surgery. Yes, it may be some of you who have had a radical cystectomy or your bladder's been removed, but it might be also some of you who sometimes are still struggling with continence issues. But one thing I first of all wanted to highlight was there were some questions around travel. So Teresa suggested we mention this, and those of you who do have a urostomy, you might want to consider getting from YVR the Hidden Disability Sunflower Program chain. And there are many of those. I certainly have some here at my clinic, but YVR, you could reach out to them and they will send that to you. What that means is throughout Canada, UK, many airports now, quite a few hundred, recognize that when somebody is wearing that chain, they have a hidden disability. And it just makes the process of going through the screening that much easier, respectful, and there isn't an issue related to you having a pouch. And I believe occasionally some of my patients encounter some difficulties, and this just helps makes the journey that much smoother when you're going through the screening and security at the airport. By the way, Teresa, I'm hoping my email address, if anybody has questions around this or around some of the topics we covered today, more than happy to share that email address of rosemary.hill@vch.ca. Recently, I've had a chance to do some presentations, and one of the things that came back from evaluations was an overwhelming people were saying, thank you, you gave your email. Because sometimes those questions, small or large, come back later. And I want to open the forum for people to certainly send me an email if there was something that they weren't 100% sure of as we go through. For the next slide, Teresa, if you could I just thought I'd touch on some of the travel tips. And I want to tell you, some of these travel tips, they come from my patients. And of course, some of them are well written up. But always feel free to bring along extra supplies. Whether you're somebody who doesn't have a bladder anymore and you are relying on a pouch, or you're a person who struggles with continence issues, go have extra. And also, a lot of my ostomy patients, they do their full change the night before. So it's nice and secure, just in case there's travel delays, and so that their appliance is secure. Keep it in your carry-on as best you can. And those of you who do some cutting, feel free to provide some or create some pre-cut flanges, and then you're not worried about your scissors. Put it in an easily identified pouch in your carry-on bag. And also, for those of you who go to warmer climates or very cold, try to keep them at room temperature wherever you're staying. Consider seat selection, that you prefer an aisle or be near a bathroom if you're a bit concerned and want that extra added support that you can pop down and empty your pouch. I have to say, and this goes across all people who travel, is keeping hydrated. But in particular, those of you with a urostomy, it's so important to keep hydrated. And yes, you may indulge in a glass of wine or two, but you're going to always want to compensate by ensuring that you have enough fluid. And so definitely stay hydrated on that short or long flight. Key variable for all who travel. Now, some of you, if with your urostomy, might use a night drainage bag or bottle. And what I have heard works the best for my urostomy patients is, sure, some of them have seen a little plastic accordion style container, but they find that that doesn't work as well. It's cumbersome to clean, and so most prefer just to carry along several extra catheter bags. Maybe it was something you went home with initially from hospital. or maybe when you had your turbot, you had a catheter bag. They find those perfect for nighttime drainage. And then you're going to just want to use some tap water to rinse it in the morning after you've emptied. Some people find it's easy to go to the dollar store and pick up a little flexible silicone funnel, and they use that, and that makes it super helpful just to rinse the tubing of the bag. I find a lot of hotel rooms now, it's a shower and you don't have a bathtub because the bathtub makes it so easy to rinse your pouch. So working at the sink with a little funnel and sending water through, that can be helpful. If you had odor issues, sometimes not critical, but if you had a little bit of vinegar in a small bottle, that could help. And we usually recommend a mixture of 3 parts water and a little bit of vinegar. If you don't want to bother with that, use a bit of mild liquid soap and then make sure you rinse it well. If you are going to go the vinegar route, you can have a little travel size cleaning bottle. And sometimes some of these little bits and pieces, like your soft silicone funnel, you might just keep that in a Ziploc bag. I know others who use a little syringe, and that works great. Keep those in the Ziploc bag for your supplies. Next slide, Teresa. Again, other resources, Ostomy Canada, the website has all kinds of traveling tips when you have an ostomy. Feel free to unpackage all the information there. Talks also again about the hidden disability sunflower. Next slide. Another place that I want to take you to is the CLIC website. CLIC standing for Connecting Learners with Knowledge. But the beautiful thing about this website is there's all kinds of information, not just about a urostomy or your ostomy, but rather also continence information and wound care as well. And yes, it's geared for many people, healthcare providers, but some of it is at a level that if you are a new person with your ostomy, your urostomy, there is information there for you as well. And I would encourage you to check out that website. There's information, again, when you're at home about how to clean your drainage bottle, and it just gives you some tips as well. And a new thing I came across, and again, as Dr. Lee mentioned, our comments, you want to individualize them. And this particular device might not be something that suits you, but I have some patients who have difficulty mobilizing and maybe are even wheelchair bound. And they use something called a bobtail, where they connect it to the urostomy. It just gives a little extra length and they can quickly empty their pouch. It's available, I think, from the States, Amazon, $20. Again, not for everybody. In fact, some people would find it cumbersome to have it under their shirt. But I just throw it out there as it was in our recent highlight newsletter that comes out from the Vancouver Ostomy chapter, and they had a little picture talking about that. Now, if you go again to that CLIC website, there are some incontinence resources, because I'm appreciating that maybe not everybody on this call has had their bladder removed, and they may just struggle with incontinence issues. So there's several devices, and there's a whole write-up, a page, step by step, about these devices with a picture. Those are male resources. Now, again, quick wrap, some people find this incontinence pad very helpful, and there's different ways to wear it depending on your particular circumstances, whether your penis is retracted or whether you have edema. And so this quick wrap has been something that a couple of my patients, after having had bladder surgery, in fact, maybe a new bladder, they have found this incontinence product fairly helpful as they work towards becoming continent. And then there are incontinence resources for female, both the Prima Fit and the Pure Wick. And again, depending on your circumstances, feel free to go to the CLIC website and you'll find out more information there. I think Dr. Lee did a very thorough job around advocating for yourself. And I loved in particular his item number 4 that was highlighted in green around bringing your list of questions, your medications, and your concerns. Um, and maybe in some cases, I remember my father very much detailing a wonderful diary, and he was measuring all of his voiding. And so he would bring his diary along to his meetings. If it's your stoma, many of you actually take pictures. That is so helpful. And you bring along your pictures and you say, well, Rosemary, it looked like this or it looked like that. Um, so those things can be very helpful. I think I think the biggest thing is being clear and specific as opposed to, you know what, I just haven't really been feeling good. I just haven't really been myself. And so you want to tease out what is not being yourself? Tell me a little bit about what that means. And maybe it's something around leakage. And also, if you have an ostomy, try to see if you notice patterns. Are the leakages happening at nighttime? Or are they in the morning? Or is it right after lunch? When do you have your leakage situations? Um, and often think about some of your questions that you might have, group them in terms of, is it around your lifestyle? Is it your diet? Is it hydration? Is it skincare? Or is it around exercise? And maybe you want to be planning for the future. Many of you have travel arrangements in the future, and you're thinking, what is the long-term monitoring? What should I plan for after maybe a fairly large surgery, like a bladder removal? What can I expect? And what symptoms should make me want to call my doctor? Right up at the top, Dr. Lee mentioned over and over again about potential infection or fever. I want to mention one other thing that has been a clue when a spouse or a partner has noticed that things are just not quite right. And you know what? It's often related to their thinking. They've noticed that their husband is getting a little bit confused sometimes in what they're saying. They're getting maybe their words mixed up. If you start to notice a little bit of confusion, your antenna should go up and say, oh, wait a minute. This is something, especially if they've not been somebody with confusion before, that often is an early sign when they're not making sense that maybe there's a little infection is starting to brew and they haven't yet noticed the signs of a fever. Um, Also, it is so key to bring somebody with you if you can. I mean, having two sets of ears is invaluable. I know, as it so happens, in 3 or 4 weeks, I'm going to have some surgery. I'm going to bring my sister along. My sister, I know, will pick up things that I might have missed because you see, the surgery is about me and I'm maybe a little bit anxious, I'm a little bit preoccupied. So if you can have a person that comes with you, sometimes it's your closest friend. I can't tell you that that is invaluable. And plan ahead. I welcome patients if they want to bring somebody along, especially to pre-op teaching. It is superb. Um, and don't be afraid to ask for clarification because sometimes as a healthcare person, I might use words that I get used to talking to around nurses and doctors, but it might be a word that doesn't make sense for you. So just say, oh, could you just say that again? Or could you just say that in a simpler way? Or many of my patients will say, you know what, Rosemary, we covered a lot today. Can you just write those down for me? Absolutely, for sure. Happy to do that. These are the things that are you advocating for yourself. When things, you're in that post op recovery, or that things just don't feel like they're going in a stable direction. Next slide. So have your checklist. Bring up your concerns, whether it's related to travel, work, or your social life. You're going to have the symptoms with you, your medication list, and bring your supplies and your photos. Try to be clear and have that support person as well. Um, you'll notice Dr. Lee and I were really passionate about the topic of advocacy. So we started with it and we're ending with it in an effort to help you feel prepared and equipped after you have surgery. Go ahead, next slide. All right. Are there any, let's tackle some questions.
Yes, thank you so much, Dr. Lee and Rosemary. You really broke down the complications and red flags in a really clear way, and then how to communicate best to advocate for yourself. So thank you. If you have any questions, feel free to put them in the chat, and I can read them out to Dr. Lee and Rosemary, but we've already got quite a few, so I will jump into it. If you have concerns about cancer popping up in other areas other than your bladder, should you consult with your urologist or your general practitioner?
I'll tackle that. And so it really just depends, again, on your cancer journey and how far along you are in that cancer journey. For instance, if you've just had your cystectomy, it's been within a year. Generally, urologists after your cystectomy will continue to monitor you for about 5 years at least, where we would do a CT scan usually around every 6 months and continue to follow you up with imaging to see if there's been any recurrence. So you will be catching any metastatic disease. In that time frame. So if you are concerned about anything popping up in and you're still actively being followed by urologists, I think it's helpful to bring that up with your urologist. The other avenue is, yes, through your general practitioner, and your general practitioner would often send a note back to the urologist, such as myself, saying, "Hey, can you reassess this patient sooner than your 6 month planned follow-up, and see about these new symptoms of concern." But if it's beyond, the 5 or 10 year mark and you're no longer connected with the urologist, then seeing your family doctor would make the most sense, as it could be a number of things that could be causing your symptoms, or giving you concern that there's other cancer popping up elsewhere. Yeah.
Okay, great. Thank you. And if you go to a different ER rather than the
Mhm.
hospital you had your surgery at, how can you best present your past history?
Yeah, that's a really good question and a really good advocacy question. In general, obviously, the number one recommendation is to always go back to the hospital that you were operated on. I can't express how important that is, but of course, I understand that you might be traveling from afar, so it's not possible. But whenever possible, it is better to go back to the same hospital because they have your notes, they have your discharge summaries, and depending on which province you're in, it might not be as connected, the healthcare notes and what has transpired in your healthcare journey. So if you can't go, I think those points that we have just raised in the advocacy part is really helpful. Bringing your list of health problems, bringing in point form what and dates of what has happened. You had your bladder cancer diagnosed on date A. Date number two, I had my cystectomy. Date number three, I finished my chemotherapy. And then just briefly, like if there, and you can add little brief notes like, were there any complications? Did I have any bleeding, or did I develop any major side effects from it? Another helpful thing is sometimes, at least in Vancouver, when patients are discharged, we give them a patient discharge summary, a patient-directed patient discharge summary. So if you keep that all in a
Mhm.
binder or a folder and bring it with you to the ER, that goes a long way. So a list of your medications, a brief point form of your medical health journey related to bladder cancer. That goes a long way when you present to a hospital which is not familiar with your previous health.
Okay,
I
great.
think even sometimes having the name as well, because
Yeah.
sometimes they'll go, I kind of had, there was something he did on my bladder, like I was having.
Yeah.
So if you actually, I know it can be painstaking and, there's spelling, but if you actually have the written name of your procedure as you
Hmm.
go through, it really helps.
Hmm. Well, Well, a point well made. Hmm.
Yeah, that diary, like you said, Rosemary, that's perfect.
Hmm. Yeah.
Okay, so if you want a certain treatment, such as a chemo flush with a turbot,
Yeah.
and that's not offered at the hospital where your urologist is located, is there anything you can do to get that preferred
Mhm.
treatment?
So that's a really good question. I wish I could answer it well, but it's very difficult for me to answer that one particular
Hmm.
question because, again, bladder cancer comes in various forms. For instance, I don't know the details of your bladder cancer, but for some bladder cancers, that chemo flush, if we know that it's a high-grade tumor, this chemo flush that we're talking about, where we put gemcitabine into the bladder, is most effective for low-grade tumors and preventing low-grade tumor recurrences. It's not as useful, the evidence shows, for necessarily high-grade tumor recurrences. So that could be one of the differences why your hospital or your physician didn't recommend it. Um, um, and also, it varies from the size of the tumor, how rapidly they're recurring before deciding on whether these chemo flushes are necessary. And then also there are surgery specific things that might preclude you from getting the chemo flush. For instance, when I do a transurethral resection and I'm worried about a bladder perforation, I may forego giving the chemo flush. Installation to the bladder. And I always tell my patients as part of the consent process that I make the decision at the end of the day whether I decide to give that chemotherapy installation. Now, I mean, again, I don't know what's being performed at Ottawa Hospital, so I don't want to comment about what their capabilities are. For instance, in Vancouver, we some of my colleagues at other hospitals sends it to another hospital to do it, and so there's a lot of different avenues and pathways. So I would again approach your family, your urologist to ask more specific questions about whether it's offered, whether you even need it in the first place. Yeah.
Okay, and we often get questions about second opinions and how to kind of go about that. And this
Hmm.
kind of wraps up into another question that is in the chat right now. If
Hmm.
you're asking additional questions and you want that second opinion, um, but you're
Hmm.
told your cancer is kind of high grade or urgent, what should you do? How do you kind of navigate that without delaying your treatment further? And I think the other question in there is, what do you do if your doctor is not being responsive to you with these questions?
Yeah.
I might
Okay.
just start. Oh, go,
Yeah. Go for
you
it,
go. I
Rosemary.
was just gonna say because you're gonna go. The one thing I was gonna say because I know the support group did ask about people about the second opinion, and I think it's good for everybody to hear from you, Dr. Lee. I do also get patients asking me this, and I'll say, you know what? I want you to know that all the physicians I work with always welcome if a patient says, can I have a second opinion? Because in the end of the day, those physicians want you to be at peace with the decisions you
Hmm.
make. And all of the doctors that I work with, they welcome it. And so if afterwards I'll say, oh, they were mentioning a second opinion, they'll say, oh, what a great idea. So I want to dispel the myth that
Hmm.
of in my experience, the physicians, the surgeons, the specialists that I work with, there's always a welcome. It's a welcome aspect when a patient says, you know what? Because the best thing for them to see is a patient who's at peace with how things are going. I'm going to pass it over to you, Dr. Lee, when the question
Yeah,
of the
Rosemary,
second.
you absolutely nailed it. When it comes to second opinions, I think it's important, as we mentioned with the advocacy part, it's just to be upfront and honest with your treating specialist. I can say that in Canada, second opinions are not as the norm, really. I mean, I came trained from the States. I did my fellowship in the States where people sought after second opinions quite routinely, triple, third, and fourth opinions as well. And
Mhm.
so it's common practice in other countries. In Canada, I suppose it's a testament to the fact that all our physicians are so well trained and strict credentialing process and so the nature of getting second opinions is not as common. But that being said, again, I echo what Rosemary said. We welcome it. The last thing I want to do is perform an operation on someone that doesn't have a full
Mhm.
trust or
Right.
a patient-doctor relationship. And building that trust is being honest. And because the patient-doctor relationship is something we hang a lot of weight on, and it's very important in terms of how I care for my patients. So being honest and saying, hey, look, can I have a second opinion? And to which I would then respond by asking, where is it coming from? Because it could be very well meaning, and I could address some of those issues right off the bat. And then, but after addressing those issues, you may not want another second opinion. So again, being open and honest. There are other ways that urologists do second opinions. Many cases are presented at our multidisciplinary rounds or what we call tumor board rounds. That's where five or multiple urologists, pathologists, radiologists are collectively in a room discussing the case. And in a sense, in essence, you're getting five, like for instance, we have five urologists at Lionsgate Hospital. So in essence, you're getting five urologist opinion all at once, along with the pathologists and radiologists. And so that could be another avenue of a second opinion. And then thirdly, I understand that patient-doctor relationship is important, and if you're not just jiving with that urologist, then being open and upfront and being and requesting a second opinion, it probably goes a lot better for everyone involved with your care. Yeah. So I echo what Rosemary said. Just be open and
Mhm.
honest. Mhm.
Okay, great. And
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 I think they may, you could ask if they're not feeling comfortable. Like I see one of the chats is they're not actually getting a response from their urologist. Then the idea is to go back to their family doctor to
Hmm.
seek out that second opinion in terms of
Hmm.
process,
Hmm.
Dr. Lee, correct?
Well,
Yeah.
yeah. I mean, whenever I receive a second opinion from a family doctor, I often request that the treating urologist makes that referral because there could be details about the operation or, the history that needs more clarification. And I welcome that. Like, for instance, like, like having the other urologist put in a second opinion. I don't have a problem with sending another second opinion. Yeah, to it if someone requests that. But you know what? Overall, it's so rare. It really is.
Mhm.
Yeah.
it would a second opinion though delay your treatment
It
significantly? I
can.
think that's the other concern.
Unfortunately, it can. With the confines of our healthcare system and resources, um, it can lead to some delays. If being honest, yeah, being frank.
I would
Okay.
say it doesn't happen that
Yeah,
regularly, though. You're right.
I know we're over time. Would it be okay if I asked just two more questions?
sure.
Sure.
Okay. So if my cancer continues after many turbits and BCG treatments, when should I talk about a different treatment course? Is there a
Yeah.
maximum amount of turbits that are actually helpful?
Yeah. So again, it's very patient specific, that question. And it really just depends on those TURBTs, what's coming back, what's recurring. If it's recurrent low grade, then you might not need anything but the repeat TURBTs. If it's recurring with carcinoma in situ, it's called, or high grade disease, or recurrent T1 high grade disease, then you move into something what we call BCG unresponsive bladder cancer. And that is a whole new discussion. There's so much evidence and science and development in this segment of bladder cancer care, in the recurrent BCG unresponsive disease realm, that you again need to talk to the urologist specifically. But it can range from second therapies. There's something called salvage intravesical chemotherapies. There is newer immunotherapies being used in this realm. And then also moving towards cystectomy, or is something that's offered for these recurrent BCG unresponsive disease. So again, I wish I could answer that question in more detail, but it really just depends on your history and your disease specifics, but pathology specifics. Yeah.
Okay, and nurse navigators, are they available to all patients or only if you're going through chemotherapy and radiation?
Mm.
Um, Good question. Rosemary, do you know?
You know what? There's the call line for nursing support. I think is it 811. Um, and I think that would be a place to start in terms of a nurse navigator. Also, of course, if you have an ostomy, then you're going to want to look for your ostomy person in your locale. And there is for our national website, you can put in your postal code. And when you put your postal code in, it will indicate where there's an ostomy clinician practicing near
Mhm.
you. So that can be helpful. The website being the nurses specialized in wound ostomy continence, and it says find an ostomy nurse. You can put
Mhm.
your information there. Nurse navigators, I'm really familiar with Aboriginal navigators, and certainly we can access those readily. Um, so, as ostomy nurses, I feel like if you have an ostomy, we're sort of your navigator when you're managing your ostomy. And yeah, so I'm not as, other than that, I'm not in BC, the term nurse navigator. Um, Not used as much as in terms of if you have diabetes, you have a diabetes nurse educator. She's your person. She is your navigator because she's going to navigate helping you walk through your medications, your diet, etc. So it's more a little bit along that line.
Yeah, we've found it's called something different kind of in every area too, so that kind of adds
Yes,
to the complication of it.
yes.
Okay, great. Well, I think we've answered a lot of questions. Thank you again for your time. Just some quick information. We have one final webinar scheduled for the year before we start our 2026 programming. You can register for this event on our website under Patients Upcoming Events. And after the webinar, a survey will pop up in your browser. We'd love to hear your thoughts on this session, any suggestions for future presentations. We really do take that into consideration when creating our programming year. So please take a few minutes to complete that survey, and it will also come via email tomorrow through Zoom. If you would like any accommodations to complete this survey, or if you have any additional comments or questions, you're always welcome to call us at 1-866-674-8889 or email info@bladdercancercanada.org. And I, of course, will share Rosemary's email as well with everyone. And just a final
Okay.
note that the Bladder Cancer Canada Volunteer Award window closes on November 30th. So if you know of a volunteer who you think goes above and beyond to raise awareness and support others, please consider nominating them for an award. You can find more information on our website. So thank you again, Dr. Lee and Rosemary Hill. We're so grateful for your compassion and your knowledge. And thank
Thank
you
you
to
for
everyone who
having
attended.
us.